Okay, so here we go. The digestive and urinary anatomy PowerPoint. Actually, I'm only covering digestive. In this one, I moved urinary to a separate PowerPoint. So, digestive and urinary, we're talking about using the bathroom. So how would you feel if your favorite bar replaced the signs on the doors with those? Would you know which door to go through? I think you probably would. There are some people out there who probably wouldn't. And that might be an interesting way to meet new people. That's actually kind of discriminatory because there aren't just two categories. There are some people who are XO, other people are XXX, other people are XYY. So I think that's probably the better sign to put on the door. I think we would all know which door to go through. Okay, so here is the oral cavity. We already know some of this because we studied it when we did respiratory. So let's just start going through. Here is the vestibule. Vestibule is the space between your cheek and your gum. Gingiva is a technical name for your gums. That's why when your gums are inflamed, you have gingivitis. Teeth, pretty sure everybody knows what those are, but you have to know specific ones. So if you start either upper or lower, the very middle two teeth are the central incisors, all right? Now let's just go down one side of the jaw. The next one over is a lateral incisor. Then next comes the canine, sometimes called the eye teeth because, we'll see why later. Then there are two premolars, sometimes called bicuspids. Those are just numbered premolar 1 and premolar 2. Bicuspid, an alternative name because they have 2 points, 2 cusps. 3 molars, 1, 2, and 3. Third molar is sometimes called the wisdom tooth. Sometimes it comes in at an angle or there isn't quite enough room and starts squeezing the teeth together, and that's why you get them pulled. One of my former students, her jaw was so small, her mandible, that they took out her second and third molar in order to make space for her teeth. Tongue, pretty sure we know that one. Hard palate, that's mostly the maxilla and also the palatine bone at the very end. Soft palate, once the bone stops, it's just soft tissue. So the soft palate, and then at the end of the soft palate is the uvula, the little punching bag. So the purpose of that actually is so when you swallow, it can block food from going up into the nasal cavity. Although you probably knew that guy in elementary school who could make milk come out of his nose. You can force, stuff past that, but under normal circumstances, that will keep stuff from getting into your nasal cavity. The fauces, we already know that's the opening of the oral cavity into the oropharynx. So you can see it on both sides of the uvula there. And then labial frenulum, that is the little piece of skin that connects your lip to your gum. That keeps your lips from flapping in the wind. And then the lingual frenulum, that's the one that connects the tongue to the floor of the mandible there. That sometimes in little kids can be too tight, and it can be an impairment to their speech. So sometimes a dental hygienist or a dental assistant or the dentist, whatever, but oftentimes they'll take assistants, so you just snip it and then everything's okay. So salivary glands, there are 3 of them. The one in front of your ear, anterior to the ear, is the parotid gland. Then underneath the mandible is submandibular, underneath the tongue is sublingual. How easy can that be? Okay. Then the tongue, lingual frenulum again, you can see. Okay, so looking into the abdomen here, major digestive structures. So the stomach, that's where food goes first, gets mashed up and chemically broken down. Then it moves into the small intestine. Remember, the small intestine is where you digest food, you break it down into smaller chunks, and then you absorb it into your body. There's no poop in the small intestine. Small intestine is purely for digestion and absorption. There are 3 regions. The first is duodenum. It's just the first 10 inches. Then comes the jejunum, about 8 feet, and then the ileum, about 12 feet. Now, on the practical, what I'm going to do is I'm making a deal with you. If I want duodenum, I'll point right up by where it joins the stomach. If I want ileum, I'll point right over by where it joins the large intestine. If I point smack dab in the middle of nowhere, we're going to say that's jejunum, okay? I don't expect you to get out rulers and start calculating and having to do ratio and proportion to figure out, exactly where it is. We won't do that. Large intestine, also called the colon, all right? So we'll see the regions of that later. Okay, the stomach. So the stomach, esophagus leads into the stomach. Esophagus, an organ, leads into the stomach. And there's the lower esophageal sphincter. This is a smooth muscle, and what it does is it normally closes off the passageway between the esophagus and the stomach. When food comes down the esophagus, it automatically causes that sphincter to relax. You want that sphincter to stay closed normally because otherwise acid from your stomach can splash up into the esophagus, and now you have acid reflux, or GERD, gastroesophageal reflux disease, commonly called heartburn. So, next comes the esophageal hiatus. That's where the esophagus goes through the diaphragm. We've seen that before. Cardia. So the first region of the stomach right next to the esophagus is called the cardia. Can you guess why? Remember, the stomach's over on the left side, and so is your heart. So that's the region of the stomach that's very close to the heart. So it's called the cardia or cardiac region. Either one is fine. Fundus of the stomach. So the fundus is the round dome-shaped area on top of the stomach. Lots of organs have a fundus, right? So this isn't unique to the stomach. When I first came to Pima 15 years ago, I sat in on Sid Lute's class just to see how they did it here. And when Sid got to this part in the lecture, she said, the way to remember that the fundus is the dome-shaped region on top, she says, ladies, just remember, it's more fun on top. I went, oh my God, did you just say that? I talked to her outside of class. I said, Sid. She said, oh, come on, Tom, I'm not as big of a prude as you think I am. I said, TMI. The body of the stomach is the main part of the stomach. The pylorus, or pyloric region, that's over by where the stomach joins the duodenum. All right, so notice there's a name for where stuff comes in and where stuff goes out. Pyloric sphincter is a muscle. Just like the lower esophageal sphincter, we want a muscle. We don't want stuff from the stomach just going into the small intestine any old time. We don't want it to go in until we're ready to have it go in. So that sphincter will open up under nerve system control in order to allow food in at the right time. Rugae are little ridges. So the stomach relaxed at rest is only about 50 milliliters. That's about 2 shot glasses. People say, oh, shot glasses, why didn't you say so? But the stomach can expand to hold roughly a gallon. So how can it expand? Well, all those little ridges are soft and they're flexible, and so that's, as the stomach expands, they flatten out. So that's the purpose of the rugae. Lesser curvature and greater curvature, those are just the curves on the inside of the stomach and the outside of the stomach. No big deal to it, okay? So, we're now looking here at the pancreas. The pancreas, I'll keep trying to emphasize this, is where you make most of your digestive enzymes, okay? Head, tail, and body. So look, the little skinny part's the tail, the big thick part's the head, the middle is the body. No big deal. Gallbladder. Gallbladder stores bile. Doesn't make bile. The liver makes bile. The gallbladder just stores it and concentrates it. Duodenum is the first region, again, of the stomach, of the small intestine, rather, first 10 inches or so. Jejunum, the middle part of the intestine. Right and left lobes of liver. So liver has 4 lobes altogether. Here you can see left and right. Right is much larger than the left. The cystic duct of the gallbladder. So get used to the root word cystic. It has several different meanings in anatomy, but one is it refers to the gallbladder. All right, we'll see more of that coming up. So the duct coming out of the gallbladder is the cystic duct. Just think of cystic as referring to gallbladder and you'll be in good shape. Falciform ligament is the connective tissue that separates the left and right lobes of the liver. Right and left hepatic ducts. So Remember, the liver is making bile, so there's a duct on each side that the bile will flow down. And those two ducts are going to join together, and we saw the same thing happen with the blood vessels, didn't we? What happens when two things come together? We call them common at that point. So there will be the common hepatic duct, okay? Now inside of the pancreas is the major pancreatic duct. That's where the enzymes will flow down into the duodenum. The accessory duct, so notice branching off of the major pancreatic duct, is the accessory duct. So there are two pathways for enzymes into your duodenum. Hepatopancreatic ampulla, so where the, let's go down here to common bile duct, common hepatic duct. So notice the left and right hepatic ducts merge into the common hepatic duct. Then the common hepatic duct meets up with the cystic duct. When those two come together, they form the common bile duct. Bile is coming down all of those ducts, but when you get to the very end, the very last segment is the common bile duct. Now, the common bile duct joins the major pancreatic duct. And just like when two rivers come together, they call it a confluence. The rivers get wider when two rivers flow together. So when the major pancreatic duct joins together with the common bile duct, they form a wide spot. That's called the ampulla. Ampulla means the wide spot, the swollen area. We saw that in Bio 201. Remember, there was the ampulla at the bottom of each semicircular canal? So that is the ampulla. And we'll see more of that coming up. Here you can see the other lobes of the liver that you couldn't see on that other picture. There's the quadrate lobe and the caudate lobe. Quadrate, caudate. Now, remembering which is which, I use a really stupid thing inside of my own head. Notice that quadrate has an R in it and caudate doesn't. And notice that gallbladder has an R in it. So I remember that the quadrate lobe is right next to the gallbladder, and that's how I remember. Caudate lobe is down there by its lonesome self. Right and left lobes of the liver again. Now, your old buddy, the hepatic portal vein. Once again, what the hell is going on with this? Well, when you eat food, you digest it, remember, in your small intestine, you absorb it into the blood. So the venous blood leaving the small intestines is full of nutrients, full of fats and amino acids and sugars. And who is the plasma protein factory of the body? Who makes angiotensinogen and fibrinogen and plasminogen and albumin and alpha and beta and gamma globulins? All those things the liver does. So the liver needs those nutrients. So the hepatic portal vein is a vein because it's heading back towards the heart. But before it goes any further, it stops at the liver. The liver steals all the nutrients out. So the hepatic portal vein goes into the liver. Gallbladder, again, there it is. Common bile duct, again, you can see the cystic duct. You can actually see both left and right hepatic ducts, and then you can see the common hepatic duct. Try that on your own. Can you see them? They don't point them out on the slide, but they're there. Cystic duct, okay, common. So here we have what we talked about a little before. You can see the common bile duct coming down, joining the major pancreatic duct. Where they come together is the wide spot, the ampulla. Now, the ampulla has to release its contents into the duodenum, but we don't want that to happen just any old time. We only want that to happen when we need to digest food. So there's a muscle there, the sphincter of the hepatopancreatic ampulla, the sphincter of Oddi, and that's normally closed. In the presence of food, that will open up. Then the contents of the common bile duct and of the major pancreatic duct will enter the duodenum through the major duodenal papilla. Remember, papilla in Latin means nipple, and so what we've got is, I say it's like a nozzle, like on a hose, the nozzle on a hose. That's what it is. At the end of the ampulla is the nozzle that will squirt the stuff into the duodenum. So again, common bile duct, major pancreatic duct, the sphincter, hepatopancreatic sphincter, and then the major duodenal papilla. Here we see then that there is also a minor duodenal papilla. They just say minor papilla, you have to say duodenal. Okay, so you can see the common bile duct coming together with the major pancreatic duct to form the major duodenal papilla, the big nozzle that squirts in both bile and pancreatic enzymes, and then the minor duodenal papilla, the smaller nozzle that just squirts in digestive enzymes. There we see all the terms I was just talking about. Okay? All right, so here we've got a cross section of small intestine. Okay? So there are these things called the plices circulares. That's Latin. I'll allow you to say just circular folds. So see those ridges? Those are the circular folds. What's going on is the fluid that is produced in your stomach is called chyme. Remember we had chyle in the lymphatic system? That was the milky white lymph that was full of the lipids. Well, the stuff that your stomach creates, kind of a soupy mixture, is called chyme. So when the chyme dumps into the small intestine, it flows through and it has to flow over these ridges. The idea is to slow it down. And the purpose is because covering the circular folds are the villi. And we saw villi when we looked at the lymphatic system as well. Remember, inside the villus is the lacteal. So what's going to happen is all the chyme now has to swirl past all the villi, and that's going to give us a chance to absorb all those nutrients. Okay? And then remember, the lumen means the empty space inside of any organ. Okay? So now, zooming in, we have the intestinal crypt, the crypt of Lieberkühn. In World War I, we flew the dirigibles and okay, so the intestinal crypt. Notice at the bottom of the villi, notice they misspelled villus. That should be Villus. At the bottom of the villi are those little holes. Those are the openings to intestinal crypts. And then in the foreground, you can actually see an intestinal crypt, all right? So again, those are villi. Microvilli are little tiny microscopic villi that cover the main villus, all right? So look at the zoomed in little section there. There are cajillions of microvilli. They're microscopic. You need an electron microscope to see them. They're so small. They're sometimes called the brush border because they're kind of like the bristles on a brush. What happens is those are actually covered with enzymes, not enzymes floating around in fluid, enzymes that are physically attached to the microvilli. And as the chyme swirls through, it comes into contact with those enzymes and they break down nutrients into smaller nutrients. They break down peptides into individual amino acids. They break disaccharides down into monosaccharides and so on. We'll see all those words coming up. Bottom line is they're breaking big nutrients into smaller nutrients so that we can absorb them. So inside of the intestinal crypt are goblet cells, and they're making mucus. So the whole point of mucus is we got to make sure that nothing ever gets stuck in the intestines. That's called a bowel obstruction. That's a very serious condition, potentially. So we make tons of mucus in order to keep everything in there really slippery, so that everything will just keep sliding through. And then you can see the lacteal. So once again, lipids get absorbed into the lacteal. See the capillaries on both sides of the lacteal? I wish I could use a little laser pointer to do this, but there's a bug in Microsoft PowerPoint. I'm sure they'll have it fixed by, well, maybe by the time I die. I don't know, we'll see. So in those capillaries, that's where you're going to absorb the sugars and the amino acids and stuff like that. It's the lipids that get absorbed into the lacteal. Then the duodenal gland, the Brunner's gland, that secretes bicarb. You see, the stomach is full of acid. So when the stomach dumps acid into the small intestine, how does acid know only to digest the food in your stomach and not to digest your own small intestine? Well, the acid doesn't know that. And in fact, you do. You digest your small intestine all the time. There are lots of regenerative cells in the small intestine. Your body's constantly having to repair it. But to try to minimize the amount of repair, the Brunner's glands, also now called the duodenal glands, they secrete bicarb. The bicarbonate ion, our own buddy, HCO 3-. That's the one that's going to try to neutralize all that acid so that you don't digest your own small intestine. Okay, so the large intestine, or colon, they're pretty much synonyms. So the cecum, the very first part of the large intestine. The cecum in some animals, like a horse, is a completely separate organ. In humans, it's just the first part of the large intestine. It's where the ileum empties in, all right? So how does the ileum enter in? Well, the ileocecal sphincter. It's the sphincter between the ileum and the cecum, ileocecal sphincter. Remember, we had the lower esophageal sphincter to control movement of stuff from the esophagus into the stomach. We had the pyloric sphincter to control the movement of stuff from the stomach into the small intestine. Well, now here we have a sphincter to control movement of stuff from the ileum into the cecum. All right, that's normally closed. It opens in the presence of material that has to be secreted into the large intestine, into the cecum. So the vermiform appendix, that's actually part of the lymphatic system. I should have covered that better in the lymphatic system, really. That's where you have a lot of the beneficial bacteria. That's sometimes if you take too many antibiotics and you kill off your own flora, sometimes your intestine can repopulate with the bacteria that are in the vermiform appendix. Don't just say appendix, you only get half credit. Vermiform. Lots of appendices in the human body. Vermiform means shaped like a worm. Then the ascending colon, all right, that's going up, so it's called ascending. Then we get to the corner. We have to turn the corner, called the right colic flexure or the hepatic flexure. You can call it either one. Why is it called hepatic? Well, because it's right next to that huge abdominal organ on the right side of your abdomen, your liver. Liver hepatic, that's the root word. Then the transverse colon going across the middle, all right. The splenic flexure, so we got to turn the corner again. Why is it called splenic flexure? You can call it left colic as well. Splenic because it's right by the spleen. Then the descending colon going down, and that turns into the sigmoid colon. Sigmoid means shaped like an S. So use your imagination. Can you kind of see how the part of the intestine, the large intestine there, is shaped like an S? Well, try harder, okay, because it sort of is. That's the sigmoid colon. That, then the entire large intestine has got like a rubber band on it called the tenei coli. What that does is it maintains tension. You don't want the colon to be completely floppy. I mean, you don't want your small intestine to be that way either. You have to have movement, all right? And your intestines are made of smooth muscle. That muscle has to contract and move stuff along. So having the tenei coli is kind of like it helps maintain tension so that you can actually get some pressure when those muscles contract. You can actually move things. And then the tenei coli, being like a rubber band, it causes the intestine to kind of bunch up and makes little pouches. Those are called haustra. Sometimes when you look at poop, you'll see like little segments in the poop. You're seeing basically the outlines of the haustra. Is that cool or what? Notice next time you flush. Then finally, the last part, the almost last part, is called the rectum. Rectum, hell, we killed him. Rectum, and then after the rectum is the anal canal. Just the last 2 or 3 centimeters is the anal canal. And then the very opening itself is called the anus. Okay? Now, a close-up here of the last part of the rectum and the anal canal. So we see the rectum, we see the anal canal, see the anus. Anus is the opening, all right? The internal anal sphincter and the external anal sphincter. Those are both muscles. The internal anal sphincter is smooth muscle. The external anal sphincter is skeletal muscle. So, as you should remember, that means the internal anal sphincter is not under voluntary control. It opens automatically whenever material moves into the anal canal or into the rectum. Sometimes, you'll see somebody standing there talking and they have a panicked look on their face, and then they excuse themselves and they start walking out of the room, and they walk with their thighs like rubbing against each other and their butt cheeks clamped together. That's because it may be that their internal anal sphincter just opened up, and the only thing holding stuff in at this point is the external anal sphincter, and you hope that works all the way until you get to the toilet. And if you say that hasn't happened to you, you're lying, because that's happened to every single person who's ever lived. Then the rectal valves. So notice those little sort of bars that come partway across. So the technical purpose, we say, is to retain feces while allowing the passage of flatus. In more common terms, that means that those are there so you can fart but not shart. All right? So the feces moves down into the rectum, and there's gas, and the rectal valves will hold the feces in while allowing the gas to get around. Assuming the feces are solid, that works. If the feces are a little bit loose, that's when sometimes you get that frantic look on your face and you realize you got to change your underwear. It was a juicy one. Okay, a great diagram here. This shows all the organs from a sagittal view, a mid-sagittal section, so right down the middle. And there's a lot of really good stuff on this slide, and I'm going to expect you to know this view, so get used to it. So first of all, the lesser omentum. The lesser omentum is a connective tissue structure that holds the stomach onto the liver. So as the stomach fills with food, we don't want the stomach to fall all the way down into the bottom of your pelvic cavity. So your stomach basically hangs off. It's kind of like the lesser omentum is like a coat hanger. The stomach hangs on the coat hanger so that it can't fall down any further. That's the lesser omentum. The greater omentum, notice that flap, it goes down kind of like an apron over the small intestine. The job of the greater omentum is not totally clear, but it is a special site for adipose deposition. Sometimes you see somebody with a big beer belly. That's not actually beer. A lot of that is adipose that's been deposited onto the greater omentum. We'll see pictures of that later. The mesentery is connective tissue that holds the small intestine in place, all right? Once again, you don't want all the folds of the small intestine, all the coils of small intestine to fall down into the bottom of your pelvic cavity. They have to be held in place so that stuff can move through. That's what the mesentery is for. Then the parietal peritoneum, visceral peritoneum, and peritoneal cavity. We've been over this in Bio 201. And in this class, in 202, we've also talked about so far the pericardium, and we talked about the pleura. Remember, there were parietal and visceral layers of both. Parietal means wall, so that's the wall of the cavity. Visceral means organ, so that's the part that's actually on the organ itself. Then the space in between the two is the peritoneal cavity. So look, there are several places there where they identify it. The parietal peritoneum, the big outside covering, and then around each little section of small intestine, for example, is visceral peritoneum, okay? Then the liver, you can see up there holding the stomach. The pancreas, so look underneath the liver, most posteriorly, and there's the pancreas. It's kind of behind the stomach, all right? And in fact, that's true. The pancreas runs behind your stomach. Then the stomach, you can see right underneath the liver again. Duodenum, so notice down below the pancreas is the duodenum. And that makes sense because the pancreas, remember, is secreting things into the duodenum. So that's how it's easy to remember that the duodenum must be that thing right underneath the pancreas. Then the ileum further down and the jejunum, you can see parts of the small intestine. You can also see there the transverse colon. Notice the transverse colon is right in front of the duodenum, and that's true. The transverse colon runs right across the middle of your abdominal cavity. Then the sigmoid colon, again, you can see it down at the bottom, and then the sigmoid colon turns into the rectum. You can see all that there. Get used to that view. I'm going to use this on the practical. So here are just a few more things. We've already seen these. Falciform ligament separating the two halves of the liver. And I forgot if I mentioned this before, but at the bottom of the falciform ligament, see that little nub? That's called the round ligament. That's actually a remnant of the fetal umbilical vein. So when they snipped that after you were born, the part that stayed inside of you turned into what's called the round ligament, which is at the very bottom of the falciform ligament. Then here we can see also the greater omentum. There it is, packed with adipose. It's a place of adipose deposition, all right? You can see the liver up there again, the stomach, the falciform ligament, okay? Here, another view showing some more of these structures. They have now removed the greater omentum. You can see the falciform ligament. Notice now the lesser omentum. See how the stomach is connected to the liver via the lesser omentum. Okay? Stomach, liver, gallbladder, they should all be easy to see. Ascending colon, transverse colon, descending colon, sigmoid colon. You can actually see the vermiform appendix there. You can see the urinary bladder too, but we're not talking about that yet. So then finally here, right, they've pulled the greater omentum up to expose underneath. So you can see that greater omentum. The mesentery, remember mesentery holds the small intestine in place. Now holding the colon in place, holding the large intestine in place is called the mesocolon. And I don't remember if we saw that already or not, but I'm pretty sure that comes up someplace again. So it's there in both cases, it's just connective tissue. So the mesentery holds the small intestine in place. The mesocolon holds the colon in place. Here again, we see the transverse colon, the descending colon, the sigmoid colon, the jejunum, and the ileum. Okay? So according to the timer I'm looking at, that took about 30 minutes. So feel free to go back through this whenever you need to. Use this slide to help you identify the digestive structures in your digestive labs. So, unfortunately, I wish I could interact with you in person. I wish I had a little laser pointer so I could point at things, but we don't. We're all going to get through this, kids. Just stick with it, okay? We're going to make it.